we'll end up with the last talk. You heard about the various models, various success stories with teleophthalmology, which is fast growing now. I'll just mainly cover the major part. What they do when the patient comes for endocrinology workup. In fact, patients are told beforehand that this is the time for their ophthalmic retina consult. They get them dilated. There's a fundus camera in the adjoining room. They take a photo, it's beamed to the ophthalmologist. Does he need any further intervention? And it comes back to the endocrinologist. So it's not always necessary that it has to be in a different locality, kilometers away or this. It can be within the same building, at different centers. That's been a success story at Jocelyn. This is telehealth, just a brief overview of the definition. That's why we added small distances also. It's not just the large distances. The present scenario, now more than nearly 150 telemed initiatives are there all over the country. But mainly so far, it has all been supported by the Department of Information Technology, the ISRO, and a few NGOs who have taken the lead. So this we need to increase, and there should be some private involvement also for it to work on a larger scale. And in 2005, Dr. Mishra and Dr. Ganpati had given a paper on the current e-health initiatives. So at that time, there were just about 6 telemed consultations all over the country in a day. Now you see, now just with the first one of the mobile teleophthalmology that Dr. Rohan had shown, almost about 10 per day he himself is doing. So it has now gone up quite exponentially. ISRO is a leading player. Just a brief slide to show how much they have contributed to the spread of telemedicine in our country. The inequality as shown in the earlier slides. We face a huge crisis in the rural-urban divide. Major challenges still before us are lack of telecommunication infrastructure, the problems in affordability, and how do we sustain the programs. Starting it is not the big problem, but how do we sustain it over the years? Cost of the equipment, accuracy and reliability of equipment and images, and training of appropriate personnel, lack of guidelines, protocols, acceptance, legal issues, reimbursement. When you come to telecommunication issues, the coverage in rural areas is still less than desired. Mobile phones coverage, we still know, are erratic. Connectivity is still an issue. Satellite is the best actually. It gives around 384 kbps and you get good real-time video conferencing and data transfer. But it's not there all over because VSAT, though the ISRO gives you a dish and gives you the bandwidth, the cost factor involved in setting it up is a little more. Fiber optic is a very good option, but remote areas, maintaining it is still a problem. And ISDN is a good option still. What we need to realize is, for teleophthalmology or telemedicine in general, you need a good and very stable connectivity. Stable connectivity is what will help us to have a successful program. There was an international telecommunication study in 2011 which looked at various modalities of teleophthalmology and telemedicine, in which 60% was satellite connectivity, 25% was ISDN, and wireless was hardly used in those areas. And now with 3G services, WiMAX, I think this should increase. We may have better coverage, and increasing ISDN would also help us, especially since BSNL has got a good network, especially in the peripheral areas also. If a good regional network is in place, then we are definite to have a stable connectivity, and infrastructure will then be improved on a very large scale. Funding, again, is an important issue. Most of the funds are there because some are NGOs, some are government sponsored, some are from big institutions like LV Prasad, Shankar Netralaya, Arvind. The bandwidth which has been provided by ISRO is free of charge. That has actually helped teleophthalmology grow in our country. Patients, now the concept is patients need to be charged some fees so that the program can sustain itself, and they should be also reimbursed. We should have a good insurance program for them. And what will work out is when it gets integrated into the national health delivery system. Equipment, we have seen the equipments. If you take teleophthalmology itself, the cost of the equipment will run into lakhs. But if, as of now, indigenization is taking place, we have smaller models, I'm sure with what you have seen over the last 3 or 4 speakers, things will improve in the long run. And if maybe the government is also thinking of allowing the private people also to run. So we have a small franchise where they have a vision kiosk so that they come, get themselves tested, and then it's linked up with the community center or with the tertiary center. And image standards, you all realize that teleophthalmology needs excellent images. The diagnosis is made basically with the images. If you have cross-border consultations, there are consultations between Moorfields Eye Hospital and Edendale in KwaZulu in South Africa. There the cost is very high initially, and it's mainly funded by the British people, UK. But later on, the cost factor becomes less once you start maintaining it on a day-to-day basis. The optimal level of compression of JPEG images is 1:40. Dr. Raman also shown this slide. About 30% losses occur, and beyond which, if you go compress it still further, you will end up with data loss. Bandwidth and global standards need to be maintained. That image should be reproduced and reliable all over the world. Familiarization of training of personnel, where they should be familiar with the software, the equipment. Doctors should also be tech savvy. And as you can see, a lot of training programs are run. Many of the rural areas, mobile connectivity is good, and people are more conversant with mobiles. So many of these images can even be seen by private practitioners on the mobiles and an opinion taken. The only problem is if you need a smartphone for some of the images, because the images are with such big data that downloading it and having clarity is a problem. So in those areas, if you take it with a desktop computer, the desktop computer is actually cheaper than the smartphone. Guidelines. It's another big issue. We don't have any guidelines, though there is a National Telemedicine Task Force, which was set up in 2005 by the Ministry of Health and Social Welfare. They have recommended some guidelines and standards. It is there in the website of Telemedicine Society of India. The Department of Information Technology, they've also got a framework for information technology infrastructure for health. Basic concept now is, should we have a national telemedicine grid, which will involve teleophthalmology and other specialties also. ISRO has actually drafted a proposal and is applying with the ministry now for clearance. Acceptance, he's already talked about the earlier, it is slowly growing. There is a feeling that maybe since you're not face to face with the doctor, the relationship may not be the same as before. And private practitioners feel that asking somebody for a second opinion sometimes is not good. In the government setup, the doctors may feel, why should I ask somebody? Patients may feel that he doesn't know that much, but he's asking for a second opinion. But these, I think, in the long run will get ironed out, because the patient obviously will get the best possible care. Language and cultural barriers, you're doing cross-country, inside, within different states also, you may need to have an interpreter. Reimbursement insurance are definitely needed. We have a good insurance program. Definitely, physician is also covered, patient is also covered, and it should not make a big difference for them then. And if you have a national insurance program, then it can get integrated. The legal issues are a problem. As of now, we do not have any laws. You've seen all these centers, all the telemedicine programs, but we don't have actually a proper consent. We don't take any consent from the patient, and neither are we following any guidelines, national guidelines. These problems will definitely crop up. There are instances where a patient had a consultation. It has happened abroad in Hawaii and in US, where the patient was asking for a neuro-ophthalmic opinion. She had a brain surgery, there was some involvement close to the chiasma. She wanted to know that she needed gamma knife surgery. So she had talked, there was a proper telemedicine setup. She talked to the physician, she was happy with the result. But suddenly another voice asked her, it was a student who was with them. The student had asked her some question. So the family of the patient felt that their privacy had been intruded upon. Because the screen shows only the consulting doctor. It doesn't show the people who are present. So these may need to be suitably modified. The other person was, when they had another instance, they had a surgery done by a visiting consultant. It was in a rural area. He went back. There was an ophthalmic nurse. So every day the ophthalmic nurse would report. But unfortunately the nurses worked in shifts, and some other nurse used to get the report from the patient who had pain every second day or third day. So after a week, the patient went to the doctor, travelled all those 100 kilometers, went to the doctor and showed he had severe uveitis and secondary glaucoma. Of course, he was treated well, but the patient sued the doctor as well as the local setup there. He said if the ophthalmic nurse had been the same nurse, taken taken the photo and conveyed by pain and diminution of vision, I would have had a better recovery. See, these are small issues. Somebody has to give you the proper image. Physician has to know what is the importance, whether the image is of good clarity, or the ophthalmic nurse has to be well trained in picking up. And confidentiality of patient's records is important. Because these are, patient would not like his records to be seen by anyone else. So data encryption will be needed and has to be seen only by the consulting physician. And though it lies in the setup, it should not be seen by other people. Strict adherence to laws and rulings. Each country, each state has its own law and rulings. So if you want to consult, now many people in radiology consult the doctors in Bangalore. Even from US, the films are sent for a teleconsultation. So these people preferably should be certified from that country from where the films or patient's consultation is asked for. These are the issues that need to be looked into, and we need to have acceptable standard of care, a global standard of care, which is very important. Modification of patient consent needs to be done, and then what we term as medical negligence needs to be looked into. And operating protocols, last but not least, should be followed by each and every staff. These are the other issues that may come up. Exact standards have to be defined, and as you know, as global healthcare improves and expands, telemedicine and teleophthalmology services have the potential to make substantial contribution at the individual level, health level, and the social level. Thank you. Any further?